Today we have Rebecca Brynjulson. She graduated from NDSU in 2004 with her PharmD and completed her pharmacy residency with an emphasis in rural health from the University of Minnesota in 2005. She serves as the Director of Introductory Pharmacy Practice Experience and Assistant Professor of Practice at North Dakota State University at the School of Pharmacy. She is board certified in geriatrics and ambulatory care pharmacy practice. So thank you so much for being with us today, Rebecca. And if you want to go ahead, we're listening.
Thank you so much for the introduction today. Well, today I have a couple of different things that I would like to talk about. And the first is giving just an overview of deprescribing medications in geriatric patients. So the objectives that we will meet by the end of this presentation are to identify the factors that should be considered in medication deprescribing, identify instruments available to guide decisions related to medication deprescribing, and identify some recently published journal articles that can help to inform providers of patients that may either benefit from medication deprescribing or perhaps maybe give us a little more evidence to keep patients on medications that we might not otherwise have had that evidence to consider in the past. So first, we'll start off with defining deprescribing. So the definition that I have here is from the article Deprescribing in Older Adults with Cardiovascular Disease. And they have indicated that a comprehensive definition of deprescribing should include an organized process of medication removal or dose reduction, oversight of the deprescribing process by an appropriate member of the healthcare team, a goal of improving one or more specific outcomes, and consideration of an individual's overall physiological status, age of life, and goals of care. In what situations should it be considered? Certainly, it would be appropriate to consider deprescribing if a patient has had an adverse drug reaction, or if you're expecting or anticipating that a patient may have an adverse drug reaction to medication. It should be considered in polypharmacy. So there are several definitions of polypharmacy, but most would agree that would be in situations where there are 5 or more medications prescribed, which actually happens quite frequently in our older adult population. Prescribing cascades. Prescribing cascades would be where one medication has been prescribed as a result of a patient potentially experiencing an adverse effect from a medication that was previously prescribed to them. And then in end of life or palliative care, it would be appropriate to consider deprescribing as well. So what are the steps involved in deprescribing? First of all, it would be important to conduct medication reconciliation or review. It takes time to get an accurate medication list from patients, and often patients don't always or may not always be forthcoming with what they're actually taking. So our prescription medications are fairly easily reconciled based on the electronic health record, but capturing some of those over-the-counter product use or natural product use may take a little bit more time and effort. After you complete a medication reconciliation or review, assess the likelihood of a patient experiencing adverse effects of each medication, prescription, or over-the-counter product. Again, this can be quite time-consuming. Consider if medications can be discontinued. If a medication can be discontinued, prioritize how this will occur. And typically, it would be recommended to discontinue one medication at a time. Discontinue medications as appropriate, and then monitor. So those are the steps for deprescribing. Again, this is a very time-intensive process, and so this is one of the barriers to actively considering medication deprescribing in a comprehensive way for patients in the clinical setting. So I have 5 M's listed here as a framework. We also have multi-complexity or multimorbidity listed here, but consider mind, mobility, medications, multimorbidity, and what matters most. This can be a framework used to help you make decisions related to deprescribing. There are a lot of different instruments that are available to guide decisions related to deprescribing, but The evidence for deprescribing is really lacking in a lot of areas because patients who are older adults have typically not been included in a lot of clinical trials that have shown either long-term benefit or risk for using specific medications. So we have both implicit instruments and explicit instruments that can help guide our decisions related to medication deprescribing. Some of the implicit instruments include the SMOG screening medications in older adult user, MAI, the Medication Appropriateness Index. There's a whole list of them here, and they all cover different drug-related problems, but not all of them or any of them are a comprehensive drug-related problem review. They all have pros and cons. All of these implicit instruments do require clinical judgment as well. The ACOV 3, or the Assessing Care of Vulnerable Adults 3, is the only one that does not require as much clinical judgment to administer. All of these have been validated in the literature with the exception of SMOG, the screening medications in the older drug user. There are also some explicit instruments that give explicit recommendations or things to consider for providers when considering deprescribing. These include the Beers criteria, STOP, and STOP frail. These are often built into electronic health records to help alert prescribers as well to potential inappropriate medications that maybe are being prescribed or have been prescribed, to identify those. They can be put into databases and recommendations can be pulled from using those explicit instruments. There certainly are barriers to conducting deprescribing in the elderly population. And so, of course, the COVID-19 pandemic has added additional barriers to this. So there's an article that's recently been published in the Journal of Research in Social and Administrative Pharmacy that talks about these barriers in the Canadian patient population. So they talk about barriers that existed for deprescribing before COVID-19. So patient-focused barriers and system-focused barriers are the two things that are discussed. Patient-focused barriers include simply change, not knowing what change will bring. Will it make things worse for them? Will they feel like their symptoms aren't being adequately controlled? Change is a hard thing for all people. And then an understanding or knowledge related to what deprescribing is. Patients who are taking some medications that you may recommend for deprescribing may have been taking them for a long time and they don't want to stop taking them because they perceive that they're receiving benefit, even if that benefit may not be true. And so there's a lack of knowledge about what deprescribing is. And so education for patients can help remove that barrier. And then again, there's concern among patients about removing medications versus replacing medications with alternative therapies. There are also system-focused barriers. So coordination of healthcare and the sharing of healthcare information can create barriers to deprescribing. Even looking at the system that we have in the United States, our pharmacies where medications are being dispensed are not integrated with an electronic health record that can communicate or can allow all providers, including pharmacists who are filling medications and providers who are prescribing medications, to see the same type of information to help guide recommendations related to deprescribing. There are also prescriber factors, whether prescribers want to consider deprescribing for patients or have experience with deprescribing. And then there is just simply limited guidance and evidence in both clinical practice guidelines and in the literature in general related to this patient population. There are also some barriers that are specific to the COVID-19 pandemic and will likely continue to be barriers unless they are appropriately addressed. So one of the patient-focused barriers is technology and virtual healthcare. So patients who are older adults may not have the knowledge and or the technology to be able to access healthcare in a virtual environment. And there is a lot of change going on right now for patients already. So starting a conversation about deprescribing or making changes during this pandemic time may be simply overwhelming for patients, where it may not have been the case prior to COVID-19. There are system-focused barriers that seem to be exaggerated by COVID-19. So again, the coordination of healthcare seems to be a little more difficult in this time period. And again, virtual healthcare, so how patients are able to access healthcare as well. So certainly there is a lot of things to consider when deprescribing, and the thing that we like to have is published literature. We like to have evidence to support our decisions, to guide our clinical reasoning, and to be able to rationally decide whether certain patients should be considered on or continued on therapies, or if those therapies should be discontinued. And I think one of the areas that seems to have the least evidence is primary prevention. And I wanted to focus today a little bit on talking about some of the recent published literature related to statins in primary prevention. There will be some other trials that are coming out in upcoming years that will help to add some clarity to the discussion that we have today. And I will be talking just very briefly about those at the very end. But I do want to talk a little bit about statins, because when we talk about statins as a whole, and we talk about primary prevention or even secondary prevention of cardiovascular disease, there is a lot of evidence. This is one of the areas that we probably have more evidence than anywhere else for what patients should be receiving as a standard of care. But when it comes to older adults, the guidelines don't provide much guidance beyond age 75. So beyond age 75, it becomes a decision between the patient and the provider, what would be most appropriate for that patient. And there's little evidence to guide what the recommendations would be, simply because at the time of all the major cardiovascular trials, elderly patients or older adults weren't included in the trials. And so they were excluded. And so we have a whole population of patients who have maybe been started on primary prevention in their in the age range that we would consider to be acceptable or recommended at this point, up to 75, who are going to become older than 75. And the question will be, do they continue on a statin for primary prevention, or at what point do you consider deprescribing a statin for those patients? So there's a lot of evidence that will be coming, and the evidence that we have now is a lot of historic looking back at what has previously been prescribed. So the first article that I'm going to talk about that addresses this issue is Association of Statin Use with All-Cause and Cardiovascular Mortality in U.S. Veterans 75 years and older. So I'm going to start with the author's overall conclusion, and then I'll give you some background too, so that you have this as your takeaway point, but we'll talk about some of the study characteristics and some of the patient characteristics that were involved in this trial as well. So the author's conclusion was that among US veterans 75 years and older and free of ASCVD at baseline, statin use was significantly associated with a lower risk of all-cause and cardiovascular mortality. Further research, including from randomized clinical trials, is needed to more definitively determine the role of statin therapy in older adults for primary prevention of ASCVD. So this trial was looking at claims data for patients that were at the Veterans Health Association or Veterans Healthcare Association. And this data was collected between 2002 and 2012. So this will impact certainly some of the recommendations that were made for therapy for these patients. And we see that most patients in this study were actually on simvastatin, so about 85% of the patients. But at the time, between 2002 and 2012, it's important to remember that Crestor didn't come onto the market until 2003. It would have been brand only. And also atorvastatin didn't, well, Lipitor did not become generic until 2011. So what we're seeing is pretty typical for this time period for treatment, but may not represent how we would, or the types of statins we would see more commonly recommended and prescribed at this time. So this study did go through all the patients that were, that had been active in the VA system for 2 years, and they took out patients that had prevalent ASCVD. So if they had a history of MI or a TIA or stroke or peripheral vascular disease or any sort of coronary revascularization, those patients were excluded. And then they included patients that had cancer, dementia, and paralysis because they wanted their patient population to reflect a more accurate practice setting. They went ahead, and if a patient had passed away within 150 days of entry into the cohort, they deleted them from the data because they found that really statin benefit, a patient needed to be on a statin for at least 2 years to see this benefit as well, and that would not have met the time period. So 2 to 5 years for benefit is what they based that recommendation off of. So there were a total of 326,981 veterans who were eligible for participation, and 57,178 became new users of statins during that time. So that was the group that was assigned to statins, and then the others were non-statin users. So these were patients that were prescribed a statin for the first time. The mean age of patients was 81.1 years. The range of ages was 75 to 107 years. 91% of the patients were white and 97.3% were men. So certainly this also impacts the generalizability of the study results to the general patient population. Again, I already said simvastatin was most commonly prescribed, and they did find that statin use was significantly associated with that lower risk of all-cause mortality and cardiovascular death. And they saw that at years 2, 4, and 6. So for these patients, certainly it seems reasonable based on this evidence that patients would be using a statin for primary prevention at age 75 years or older for patients that meet these criteria. Again, this is looking retrospectively at claims data, so there are some limitations related to that as well. It's not clear if everyone was captured that could have been captured. There are also, when we look at limitations of the study, we also consider that the statin that's being prescribed is not the most commonly used right now in practice, although statin benefit is generally seen as a class effect based on intensity. So that might be something to consider as well. The other article that was published in July of this year is Association of Statin Use with Disability-Free Survival and Cardiovascular Disease Among Healthy Older Adults. And this was actually a secondary analysis of the ASPREE trial. And the ASPREE trial is aspirin in reducing events in the elderly. This was for community dwelling adults who were either 70 or older than 70 years of age, but they didn't have a lot of patients enrolled that were over 85. And again, this patient population was primarily Caucasian population, but it did have a more equal distribution of men and women than the previous study that we talked about. So the author conclusion for this study was that among healthy community dwelling adults greater than or equal to 70 years of age, statin use may be beneficial for preventing physical disability and cardiovascular disease, but not beneficial for prolonging disability-free survival or avoiding death and dementia. Future clinical trials are needed to confirm these findings. So again, this was a secondary analysis of the ESPRIT trial. The ESPRIT trial, that aspirin in the primary prevention of cardiovascular disease, that trial is the trial that formed the basis for the recommendation in the 2019 Beers criteria that says to use aspirin with caution in patients who are over 70 years of age for primary prevention. So that is the trial that this came from. So again, there are some barriers to looking at a secondary analysis. So we're looking at data from the perspective of it not being the primary outcome that the researchers were studying, but the researchers did do a good job of trying to take into account all of those different criteria in making their finding. And this, while it is not necessarily a finding that's going to change the way you practice with this type of level of evidence, it adds to the discussion, and it also points toward the importance of having more definitive answers to be able to determine whether or not patients should remain on a statin for primary prevention as an older adult. So the evidence that is yet to come, these are things that we will be looking forward to seeing in the future, some results that can help inform our decisions a little bit more. So there are some clinical trials that are in process or in progress. One is statin therapy for reducing events in the elderly. And for this trial, I believe that I saw that the results should be available at some point during 2020. This trial is again in community dwelling adults over 70 years of age. This is a trial out of Australia, and the trial that we just talked about was Australia and the United States. But they're going to be looking at death or development of dementia and disability and time to major fatal or non-fatal cardiovascular event. And they have two groups. One would be atorvastatin 40 milligrams and the other would be placebo. So that's the evidence that we can look forward to from that one. The other trial is the preventable trial. And it is pragmatic evaluation of events and benefits of lipid lowering in older adults. And this is aimed at community dwelling adults that are greater than or equal to 75 years of age. And they're hoping to recruit patients from 100 US sites. And they will be looking at atorvastatin 40 milligrams or placebo for a 5-year period. They'll be looking at dementia and physical disability as primary outcomes for this trial. So again, this information will be really interesting. So it's my understanding that at this point, due to COVID-19, the preventable trial is on hold. They're not recruiting patients right now, but once that begins again, we can expect results about 5 years after that, 5 to 6 years after that begins, unless they were to end it early. Okay, so with that, that ends the discussion about the new trials that are coming and the 2 that are out there right now. I thought that it would be good to just have some discussion as well amongst the group about what your thoughts are regarding primary prevention for cardiovascular disease for patients who are older adults.
Absolutely. Again, feel free to just either comment in the chat box or go ahead and unmute.
Yeah, so Rebecca, the big issue with statin use is when do you get rid of them?
That's exactly it. And so there's some pretty clear evidence that certainly if a patient is at the end of life or palliative care, that is recognized by most providers, most studies as being an appropriate time to discontinue the statin. But at any time before that, there's a lot of uncertainty and people don't want to make a wrong decision, if that's the case, and have a patient have significant disability or death due to a cardiovascular event that possibly could have been prevented by a statin.
Yeah, I was going to say that it's interesting that the Esprit study really addresses the geriatric 4Ms of what matters, in a sense that if it prevents future disability, that would be a huge impact. And I guess do you know like how much it prevented disability? Was it a big effect, moderate, modest, or low effect?
You know, I don't know that it was real clear because it was a secondary analysis and they weren't really powering, I shouldn't say powering it, but that wasn't the original intent of the study. So they're looking back to see what they could see or what they could find. And one of the commentaries that I read about the study indicated that for patients who were robust patients, who were really young older adults, if you want to say that they really might benefit from continuing on a statin based on this evidence without continuing on a statin based on this evidence. But a more frail patient who maybe has difficulty or has had difficulties with adverse effects or adverse drug reactions related to statins maybe wouldn't be as likely to want to be on a statin in this situation.
Does anybody have any questions or comments at all?
Well, I can continue. I've got plenty.
Absolutely.
So going back to the adverse events, I mean, one of the things we see clinically is a lot of GI side effects. So, we see constipation, we see diarrhea, we see anorexia. And, a lot of times I think people, in particular with constipation, blame it on old age, or in, sedentary lifestyle, which may be true, but then the question is whether the medications are causing that. How do you approach GI side effects in terms of, trying to identify it as whether it's drug related, medication related, and if there's options within a medication class, does that make sense? This is all those things, like the Alzheimer's drugs, the acetylcholinesterase inhibitors, receptor inhibitors. I mean, they can cause a lot of GI side effects. And are they all very similar, or would you switch to one versus another? So those are some of the questions I would have.
So I think that I'll just talk about really in general or broad, and then if it's some specific things, I may have to look up a little bit and get back to you about those specific examples if people have questions. But generally speaking, one of the first things I would say is if you're working with patients and they have a really complex medication history and you're questioning if some of those medications might actually be causing adverse effects that the patients are experiencing, please feel free to give your pharmacist a call. I think that's something that's really potentially underutilized. So if you are if you're in a more rural setting and you feel comfortable communicating with your pharmacist and having them work with the patient, that can certainly be one way to have another set of eyes looking at those medications to determine if those adverse effects could be medication related. Even if you're not in a rural setting, if you feel like you could give a call to your pharmacist, I would certainly recommend that. And so the patient's pharmacist, where they normally get their prescriptions filled, would be the pharmacist that you would want to reach out to. And a lot of times our pharmacists across the state of North Dakota have student trainees that are with them. And so they have the ability to access resources from the university and resources from their facilities as well to do a more comprehensive medication review for a patient. And so I think that's a really good resource that maybe people don't always think of. Some clinics do have a pharmacist on staff that is in your clinic that can also provide that medication consult or medication reconciliation and review process. The other thing that I think about when it comes to determining side effects from medications is if you have access to a really good drug reference, you can also look up the incidence of those adverse effects. And certainly the higher the incidence, the more likely you might be able to attribute that adverse effect to medication that the patient is on. And then finally, the last thing that I would also recommend kind of from a overall investigative kind of view is to look at the timing of things. When did the patient start having the adverse effect? Was it after the addition of a medication? And if so, that might be the first medication that you look at. So if you started a patient on a medication a couple of months ago and they have noticed an increased incidence of some sort of GI effect, you might consider whether it would be appropriate to change them to an alternative medication to potentially investigate if that medication itself could be the cause.
Great, thank you. Do you know, is there a preference for deprescribing to either just completely stop the medication or to wean it, to go in lower doses and then get rid of it?
I think it depends on the medication itself and the effects of the medication in the body. So there's some medications that you wouldn't want to stop abruptly. So like beta blockers, for example, you would never stop those abruptly. But then there are other medications where it's not as critical. So if you decide you want to stop a proton pump inhibitor, you usually don't have to titrate that down to stop it.
Yeah, good. So with the beta blockers, we see a lot of patients who are not beta blocked. They're supposedly on a Medicaid. We had a lady with carvedilol, 3.25 milligrams, and her heart rate was 88. So we're wondering whether she just wasn't taking her medication or whether she was not getting enough of it for the beta blockade. Rebecca, you're on mute if you're talking.
Sorry. I was going to say, certainly asking about adherence to medication is always important when you're assessing anything. And so it's hard to know how patients are taking their medication at home without asking really specific questions sometimes to them. So if you are relying on the intake that you might have in clinic from when the patient is going through the medications with a nurse prior to your visit, they may or may not have been entirely truthful in that visit. They may have said, yes, I'm still taking this. Yes, I'm still taking this, because they don't really know which medications are which, or whether that's the one they take every morning or not.
Yeah, I agree. A lot of times we'll ask our patients, how is this medication doing for you? Is it helping or make any difference? And I'd say 90% of the time they say, we don't know. So I'm not sure that there's much of a connection between, people's understanding or recognition of medication side, either efficacy or side effects. I mean, that's, like gabapentin is a classic. How's that medication doing for you? And it's like, I don't know. It's not always. It seems like it always gets added on to the the pain regimen, whether it's neuropathic or otherwise type pain. And I never really get a good sense from the patient as to whether they think it's making any difference in their life.
Right. And I think too, it can be hard for patients who are taking medications like statins or antihypertensives, because you don't necessarily feel different per se when you're taking those medications. And so it can be hard for patients to fully or to maybe feel like they're working well or not, because unless they have a reading, like they check their blood pressure and they know it's working, or they get their cholesterol levels and they know it's working, it's not something you would normally feel different from per se.
Yeah, I guess by contrast, a lot of times we'll see patients with elevated blood pressure. They're 160 systolic and maybe even higher, and they're complaining of dizziness. And it's likely that the elevated blood pressure is contributing to that, lightheaded feeling or
Yep,
dizziness.
that's true.
I would also mention that there's an online calculator called ePrognosis from the University of California, San Francisco. Again, ePrognosis, which can be used for evaluating end of life, life expectancy, and sometimes these calculators are good to come to an understanding as to whether medications that are used for primary or secondary prevention really make sense for continuation. Of course, in my case, I'm always not making a good prognosis, and end up the patient will end up living to 105 when I expect them to have 2 years of remaining life expectancy at the age of 92. But so it's always a word of caution. But yeah, ePrognosis is a good calculator. And there's other calculators for heart failure, for example. The University of Washington Seattle Heart Failure Index is another good one. And then the life tables from the Center for Disease Control. So basically, he takes the average life expectancy of 80 to 81 years of age, and then you start subtracting or adding years of life expectancy, based upon their lifestyle. So if somebody's 81 and physically active, chances are they're going to live to 92. Somebody who's 81 and smoking, heavy drinker, morbidly obese, that person probably has 1 to 2 years of life expectancy. So those are the ways that you calculate for each chronic disease that's not well controlled. You subtract from the average life expectancy, and for every higher quality health intervention, such as good blood pressure control, good BMI, and good physical activity, then you start adding years of life expectancy. So I wonder, Rebecca, if you can tell us a little bit about your thoughts on deprescribing opioids, kind of what's the approach for that? I know you have the one RX program for identifying opioid misuse, and I don't know if you just want to talk a little bit about that.
Well, thank you for that. I don't know that I'm really a good expert on deprescribing opioids, but I do know that there are a lot of clinical resources available, and certainly considering deprescribing of opioids is appropriate in this current climate that we're in with the opioid misuse and opioid trying to identify patients that maybe don't need to be on opioids or on as high a dose of opioids. So I think that whenever you're thinking about opioids, you also should be thinking about other methods of pain control. And so I think that sometimes those things aren't necessarily considered as much. We tend to go toward medications right away, but sometimes things like physical therapy, I think, can be helpful for patients, or that there are other things that can maybe help to improve a patient's pain or their ability to be mobile and move around, and can then decrease the need for opioids.
Yeah, that's a really good point. And a lot of times I'll recommend people who do have pain to take Tylenol before they start their physical activity, whether it be walking or any type of physical therapy, because a lot of times people don't take their pain medications before they do it, and then they start having aches and pains, and then they can't finish their physical activity program. So I think those two go hand in hand. anybody have a particularly difficult case that they encountered recently that they'd like to share?
I don't have anything coming through in the chat box at all. Do you have anything else, Dr. Jurevich or Rebecca, that you want to add, or should we conclude a little early today?
I was just going to kind of comment overall again that there are all kinds of tools that are available to consider deprescribing or to think about whether medications are appropriate to use in older patients. But at the end of the day, they're all just guides, because the person in front of you is the person that you're taking care of, and they may have different goals and different ideas about what they're hoping for their therapy or what they want out of therapy. And even though something may not be ideal for them, that may be really important to them. And so it's important to think about guidelines as guides, as the starting point, but never the ending point for patient care, especially in older populations, because regardless of which disease state you're looking at, it's so important to remember that this patient group is underrepresented in all research. And so the evidence and the guidelines are often being based upon things that maybe aren't, or characteristics that maybe aren't the same in an older adult population. And so it's really important to be critical about how our recommendations apply to an older adult population, and to really advocate for additional research in this population to be sure that we know how to best treat patients who are older adults.
Yeah, I would echo those comments and sentiments about, you know, more inclusion of older adults in these population studies. I mean, the same thing's going to occur with the COVID vaccine. You know, do they have a adequate representation? And I was thinking to myself, I said, we have two presidential candidates that probably should roll their sleeves up and get the COVID vaccine to demonstrate to everybody that they're, you know, it's got everybody's welfare in mind here. But yeah, and I would say there's always trepidations about deprescribing. I mean, you know, from my perspective, I'd love to get rid of PPIs as much as possible, just because of their negative impact on bone density and, you know, their increased susceptibility to C. diff colitis. But then, you know, you go ahead and do a fairly aggressive deprescribing PPI, and every once in a while you get somebody that gets some rebound bleeding, you know, gastritis, you know, because they needed that. So it's always, you know, with caution that you look at these deprescribing, you know, efforts. But
exactly, and that's why a one-size-fits-all doesn't really work for deprescribing. So it's really important to use the tools that we have, use the evidence that we have, and then use your clinical judgment and consider the patient before you and the decisions that you're making.
yeah, I think that the biggest opportunity, quite honestly, is the post-hospitalization deprescribing. So people I think generally should have a high level of alertness to deprescribing when somebody leaves the hospital. And that's both true for patients that go back home and then patients that go to nursing homes. The biggest offender, of course, is patients had delirium and they were prescribed Haldol, and that Haldol is continued on into the long-term care setting, which is not appropriate. So.
And then I also should just add a statement that you may do a comprehensive review of patients' medications. They may have a long list, and they may all be perfectly appropriate for that patient. And so it is possible that you will not find something that you need to deprescribe for every patient. Yeah,
and deprescription can also involve both elimination of the medication, but also a reduction in the dosage,
The
you know,
dose, yep.
the burden, yeah. So, yeah, I'm always,
Especially, oh, I
Go
was
ahead.
going to say, especially considering renal function and liver function of patients and how that impacts the medications that they're prescribed as well.
Yeah, yeah, exactly.